Well, thanks for that kind introduction. Again, yeah, I'm Rich Bernert. I'm a pathologist, and today we're going to be talking about the EPISEEK assay, understanding what it does, some of the limitations, and what to expect when a specimen is submitted to the laboratory. I think this presentation will help you understand the test, be able to explain it to patients better, and make sure that they're shared or supported decision making, so they really understand what the test means when they do it. So the problem that we're addressing today is cancer, obviously, and it's not just the burden, which is enormous, more than 2 million new diagnoses each year, more than 611,000 deaths in the US, obviously a global problem, and we decided we needed a global solution for this. But if you look at the cancer, not only is it just extraordinarily expensive and taking a bunch of lives and causing enormous suffering, the real burden is late detection. When we're able to detect cancer early, we actually can have pretty favorable outcomes, not only less suffering, less dying, less costly, just a much better outcome for the patient and for their family and friends. So our goal was to look at earlier detection to figure out how to do this. Right now, only about 14% of new cancer diagnoses are detected from screening. So most of the cancer diagnoses that are coming forward are because there are signs and symptoms, and that usually means advanced stages. And again, advanced stages tend to be associated with very poor outcomes. So currently, there are only four cancer types that the American Cancer Society recommends screening for. What is it that we're trying to accomplish with screening? I mean, this seems almost silly, but we do need to say it out loud. Really, the idea behind screening is to get into a situation where folks that are doing screening are finding the cancer earlier. It's going to reduce the likelihood of morbidity and mortality in the population that does screening versus those that are not. And of course, it's a balance, just like everything in medicine. There has to be more benefit than there are downside risks. So some of the downside risks to think about are the cost. It takes time to go in and get screened for testing. Currently, it's one test per cancer type, and that can add up to days away from work. There can be problems associated with false positives. If you think about breast imaging currently, for example, most of the abnormal mammograms are false positives, and there's a lot of angst and anxiety until there's either an FNA done or a biopsy done or further imaging. So these are things that we need to think about. And finally, a workup can take people down, an odyssey of medical exploration. So we don't want to create anxiety that's costly and going to create more problems than benefits. So again, in the US currently, there are really only four cancer types that the American Cancer Society recommends, and you see them here. Breast imaging, whether it's mammography, ultrasound, or MR. Colorectal, typically endoscopy, but also there are fecal tests, and there's a new single cancer detection blood test that should be available shortly. Cervical testing or pap testing has been around for a long time. Uterine cervical cancer isn't a top 10 cancer, but we have made an enormous impact with screening. In some parts of the world, cervical cancer is more problematic for a number of reasons. And then finally, lung cancer. And these are for folks that have a high-risk smoking history. So most people do not need to get low-dose CT annually unless they have that smoking history or still at high risk. But these tend to underperform for a number of reasons. Again, people taking time away, they're somewhat unpleasant. There's worry about false positives and false negatives. So, this really results in that too many cancers are being diagnosed late stages where the outcomes are just not favorable. So if you look at the cancer types that ACS recommends on this top ACS graphic, you can see the new cancer diagnoses each year for men and for women. And then on the bottom half, you see the ones that are actually taking lives, the 611,000 per year that are taking lives. And you can see that current screening really only addresses a handful of these. Now, granted, we can be grateful that these are some of the top cancer types that are taking lives. But again, the vast majority of cancers that are killing people have no screening of any kind. So that's really why we wanted to develop this multi-cancer detection test. You can see I put an asterisk by the prostate for screening, and that's a little bit more of a complicated story. ACS doesn't recommend screening. The U.S. Preventative Services Task Force doesn't. The urologic groups do. So it's a little bit of a subtle conversation that I just wanted to mention. There are screening tests like PSA, that can be almost too sensitive when they were followed by immediate biopsy, which probably led to overtreatment. So a little bit more of a nuanced conversation for PSA, but there is PSA screening available. Our solution to this was to develop a single test that detects multiple cancers at one time, because the idea of getting 20 different tests for 20 different cancers is just, it's untenable. So as nice it is that we have progress today, the idea is that we don't get to pick in advance which cancer type we're going to get and then get screened for that particular cancer type. So you can be very vigilant at getting these routinely recommended cancer screenings, but there's a good chance you might end up with pancreatic or liver, gastric, esophageal cancer. So multi-cancer really is the way to go. Well, how does this work? So even when cancers are small, stage one, say growing in the lung, the cells are multiplying, and as they grow, as the tumor starts to grow, occasionally some of the tumor cells will die through apoptosis or apoptosis. And as that happens, that abnormally methylated DNA that actually makes it a cancer gets released out into the bloodstream. We're able to capture that fragment of abnormally methylated DNA or cell-free DNA or circulating tumor DNA, capture that with a peripheral blood draw with phlebotomy. And then we develop probes in the laboratory. Originally, we just designed around 10 big cancer types to try to have an impact. And you can see those cancers there on the right. But as it turned out, the way we designed these probes and selected them, it detects more than 25 different cancer types. And the more studies we do, the more cancer types we're identifying. But we're not surprised by that at all, because when we designed the probes, we looked at the least common denominator. What do all these different cancer types have in common that's not seen in normal tissue? So we anticipate the numbers will continue to go up for the different cancer types that we test. So this is something you can share with your patients as far as shared decision making and what happens next. So once the specimen's been collected, it goes into that return labeled package to our laboratory in Tucson, Arizona, and it gets accessioned the next morning into our laboratory information system. We make sure that the specimens are intact, there hasn't been leakage, there's not bad hemolysis. And then following centrifuge, we're able to take that plasma, and that's again why we use the special collection tubes called Streck tubes. We don't want the white blood cells to break in transit, but we take that plasma, leave the red cells and white cells behind, and we process it through our instruments and really use PCR instruments again because it's a scalable approach versus some of the other approaches out there that are just not practical to be set up across the globe. We use those PCR outputs with a proprietary classifier and determine, is this the pattern that's seen in normal or patients that don't have a malignancy inside of them? Or is this a pattern that we typically see when patients have a malignancy inside of them? And that classifier is going to give a qualitative output. We don't want to give a bunch of data with different numbers. We wanted to make this a single, simple one-page report. Am I likely to have cancer, or do I probably not have cancer? And just keep in mind that if we do have an abnormal report, you will 100% get contacted by us. We don't want the patient or the ordering healthcare provider to not feel like they have a good understanding of what next steps are. So it'll be a nice refresher to speak with one of us in the laboratory when we do have a positive result from one of your patients. So how does the test do? So EPISEEK, again, from Precision Epigenomics, has detected all of these cancer types that are before you. And again, this is the ACS graphic. We've put a little arrow indicating cancer types that we've detected. So the most common cancer types on top and the most common fatal cancers below. And we've been able to detect all these cancer types. And, we can get into the weeds and talk about all the different cancer types that are out there, but, let's stay focused on the big stuff. These are really the cancers that are having the most impact. There on the right, you can see additional cancer types, including stomach, cervical, testicular cancer, plasma cell myeloma, and such. Those are important too, but really the most important thing that we're focused on is getting a patient tested, something that they'll do to detect all of these different cancer types that are impacting patients and taking lives. So a little bit more detail on it. We looked at different cancer types, and we focused on the cancers that don't have screening that's recommended by ACS, or the U.S. Preventative Services Task Force, and that have aggressive behavior or poor 5-year survival. So most of the cancer types that we've targeted are fit that bill. So no current screening, and you can take a look at them real quick, and aggressive 5-year behaviors. They're aggressive cancers with poor 5-year survivals. So you can see that we're detecting brain, oropharyngeal, stomach, lung, pancreas. We included lung because although the ACS recommends annual screening for those smokers, the compliance is so poor that it's essentially not being done. In the state of Arizona, where the lab is situated, the compliance is like 1.3% of people that are high risk smokers are actually getting low dose CT each year. So really, we felt it was reasonable to include lung there, but we did not include breast and colorectal, for example. So how does it do? Well, one more thing. Glioblastoma or brain cancer doesn't have conventional staging, stage one, stage two, stage three, but we did lump it in with stage one and stage two here because there really isn't a good alternative for brain. But be that as it may, if you look at those second set of bars, you can see that for the targeted cancers for stage one and stage two, in other words, it hasn't spread yet, and that's what we consider to be early. The performance is 57% sensitivity. In other words, if there are 100 folks in a room that have stage one and stage two, lung, pancreas, liver, endometrial, esophageal, these cancers, we're going to be able to detect 57% of them. Well, right now, the sensitivity is zero because, again, there is no screening currently available for these aggressive cancer types. So while 57% might seem not great and you want 90%, again, I think we need to be realistic. Right now, it's 0%, and diagnosing 57% of those when they're stage one and stage two versus waiting until they're stage three or stage four, which is where we are today, this is a big advance in my view. If we look at all the cancer types, that's going to be the gray bar. It doesn't perform quite as well because some of these cancer types, like thyroid, for example, reasonably common, but not necessarily one of the big killers. It's not one of the top 10 for mortality. It grows a little bit more slowly. It doesn't release quite as much circulating tumor DNA. So if we look at all cancer types, it's lower at about a third, but still that's pretty good. And again, our focus was on those stage one and stage two early cancers. Do take note when you're comparing to other folks out there that are doing similar testing. Some of them will include stage three, which has regional lymph node spread typically in their early cancer detection. And for us, metastatic carcinoma doesn't qualify as early in our view, but some people see it that way. So let's talk a little bit more about the sensitivity, specificity, and predictive values. I've already shown you for the targeted cancer types, 57% for stage one and stage two. But what about the specificity? In other words, how good is the test at not overcalling negative people? So if we have 100 people in a room and all of them have no cancer at all, with absolute truth, we know there's no cancer in those patients. One of those patients will probably end up with a false positive in the assay. And that's what that specificity of 99% means. If we were to lower the specificity to 95%, we would actually have a little bit better sensitivity for some of these cancer types. But we don't want to inundate the system with too many false positives, too many people getting follow-up exams. So there's a fine balance. And most folks have suggested that 99% is a reasonable place to be for specificity to get as much sensitivity as we can without too many false positives. But it is open for discussion. The positive predictive value, this has to do with cancer is not terribly common in any 100 people that you see on the street. So even with a specificity that high, there's a good chance there'll be false positives. So let's just say, for example, that we have our 5 most recent abnormal or positive EPISEEK screening tests. We take those 5 and we look at them. The positive predictive value of 40% means that 2 out of those 5 that we examine with PET CT or other imaging modalities will end up having a clear-cut cancer diagnosis. So that's 40%. 2 of 5 is 40%. The 3 or 60%, we are going to do PET CT and look for cancer and not see anything. And in those situations, if we don't see cancer in the next 12 months in follow-up, then we consider that to be a false positive. Now, it is possible that some of these 3 false positives are false positives. In other words, there's a very small cancer in there that's not able to be picked up on scanning, but that seems to be extraordinarily unlikely, but still plausible because the immune system can fight off little tiny cancerous or precancerous lesions that might give an abnormal result but aren't picked up on imaging. But in that case, again, they're so small, it's probably not as hugely important and can be picked up the following year. The negative predictive value, how likely is it that a negative or no cancer signal detected is going to be impactful and correct? And that's 99% of the time. So, and the odds of having cancer, if you get a normal result from us, no cancer signal detected, are very low, but they're not zero. Again, there are small cancers and certain cancer types that don't release enough circulating tumor DNA to be picked up by the assay. So again, there are some limitations of the study. I just want to make sure patients and ordering healthcare providers understand that. So if we look at this, you can see the target cancers again in the upper left, and the cancers are labeled below on the axis. You can see that for some cancer types, gastric, cervical, oropharyngeal, for example, liver, the assay does very well because these tend to be more aggressive. They're releasing more circulating tumor DNA. But if you look at prostate, for example, and this is true for other assays that look for circulating tumor DNA, they just don't release that much circulating tumor DNA into the bloodstream for the assay to detect. So we fortunately do have PSA and imaging to help guide the hand for screening for prostate. Again, going straight to biopsy after an elevated PSA may or may not be judicious. We've tended to overtreat a lot of low-grade indolent prostate cancers and put men in a position where they're incontinent and impotent over a small prostate cancer. They really might not have impacted their health, wellness, or longevity. But I do want you to understand this graph as well. It doesn't perform as well for some cancer types as others. So this is going to be the most common result that you get, which is a cancer signal not detected. And this is because of that great specificity that we have, and also because most patients walking around don't have cancer inside them. This is, again, a screening test to find those aggressive cancers before bad things happen. Again, I want to make sure that people understand the sensitivity is not 100%, and small cancers could be missed. And for that reason, we want to make sure that patients understand the assay looks for, is there cancer in me now? And it's very good at doing that, but not perfect. But it does not predict if you're at risk for getting cancer in the next 2 or 3 years. So this is thought to be in addition to or complementary to conventional standard of care screening. It should not be taken that, oh, I'm negative, therefore I'm going to forego my fecal test or colonoscopy or breast imaging. I had a negative EPISEEK test, therefore I don't need to do that. That's not what we want to communicate. And that's why we have ordering healthcare providers to explain these results to patients. So the abnormal methylation signal detected, and to be clear, because of that positive predictive value where only 2 are true positives, the abnormal methylation signal detected, we say that instead of cancer signal detected because the patient is not being diagnosed with cancer. This is a screening test designed to identify folks who are at a higher risk of cancer and worthy of additional attention, looking at them closer. Maybe it's through additional laboratory work, maybe it's more imaging. It could include biopsies. But we just want to make sure people understand an abnormal methylation signal diagnosis is not a diagnosis of cancer. So it simply means that a person who gets this result versus the much more common result you saw on the prior deck, or the prior slide rather, this person is worthy of getting additional workup. Again, imaging, studies, proteins, for example, for myeloma, perhaps. And we can talk through that when we discuss this, because again, we will not just issue this report and walk away, throw the report over the wall and wish you luck. We're going to reach out to communicate with you directly to talk through the case, find out if the patient has a history, what next steps might be, what's a reasonable approach. So this has already gone a little bit long, and I apologize, but I just wanted to give an overview of how the assay works, where it has strengths, what its limitations are, because shared decision-making with your patients when they're thinking about this assay, I think is really important. We want both the provider and the patient to know what they're going to do next, regardless of the result, whether it's a no cancer signal detected or an abnormal methylation signal detected. There should be a clear plan on what we're going to do next, how we're going to proceed, and continuing routine conventional testing. So, I firmly believe that earlier detection will extend wellness, our health span, and even our lifespan and our longevity. And if you have questions, don't be shy. Please go to our website. You can contact us and communicate with us directly or reach out to Avexia, and Avexia has some great information as well. So thanks so much for your attention. Again, I'm Rich Bernert, and I hope you enjoyed the presentation, and feel free to share it with friends.